5, so it's probably...
Okay, we can go ahead and get started. That's okay with everybody. We'll go ahead and get started. For those of you that don't know me, I am Bonnie DeBobo. I am the program manager for the Heart Disease and Stroke Prevention Program, and I work very, very closely with the Kentucky Heart Disease and Stroke Prevention Task Force. And this is their inaugural Task Talks event. So thank you for joining us. We're thrilled to have you with us. The first Task Talk topic is Masterclass on Dyslipidemia. And we're very fortunate to have a team with us, and Lionel is going to introduce that team from the National Minority Cardiovascular Alliance. So I'm going to hand it off to Lionel so we can have as much of their good information as possible in the time we have allotted. So thank you all very much for joining us today. Thank the NMC Alliance for doing this for us and being our first session in the Task Force Task Talks.
Bonnie, thank you so much for the opportunity today. We were very grateful. I'm Lionel Phillips. I'm the chairman of the board of the Make Well Known Foundation and the National Minority Cardiovascular Alliance. And it's a pleasure to be here and also representing Jessica Siegfried, who's the director of this alliance. The masterclass on dyslipidemia is really in response to the high rate of uncontrolled cholesterol as well as triglyceride within minority communities. This class has been designed in partnership with really leading experts in minority health as well as cardiovascular disease, including dyslipidemia. And I'm referring to Dr. Kevin Thomas out of Duke. We also have Dr. Latha as well as Dr. Rodriguez out of Stanford, and also the Camden Coalition of Healthcare Providers. All has been significant contributors to the development of this program. We're fortunate today to have Dr. David Kuntz as well as Christine Baffo to deliver this important program. And I would just encourage, as we're presenting this, make note of your questions, to insert them during the program, or we certainly have some time after the program for your questions, also using the chat feature. A couple of comments around Christine Baffo. She's a project manager with the National Minority Cardiovascular Alliance. She's had over 5 years in the industry of healthcare, and we're certainly pleased to be hearing from her and her starting this program, kicking this program off today. We're also very pleased to have really a world-renowned internist, Dr. David Kuntz, who serves as the professor of medicine and founding associate dean of diversity and equity at Hackensack Meridian School of Medicine. He also serves as the co-chief academic officer for Hackensack Meridian Health, also the vice president academic affairs at Jersey Shore University Medical Center. Following today's webinar, would like, if you would not mind, to coordinate with David Davis, our contact at Kentucky Heart Disease and Stroke Prevention Task Force, for the dissemination of the Masterclass Toolkit. We also would like, if you don't mind, you to respond to our ask around the evaluation. We really want to get the sense from you as to what you thought of the program and what value does it bring into the community. Lastly, I do not want to overlook our sponsors that provided unrestricted grant support, that being Amgen as well as Aspirion. So we're very grateful to them. With that said, again, thank you for participating today. And I'm going to turn it over now to Christine to start the Masterclass program. Again, welcome everyone.
Thank you, Lionel. So as Lionel mentioned, we are really grateful for the opportunity to be able to be part of the first task talk. I just wanted to go a little bit over, who we are, who the National Minority Cardiovascular Alliance is. So we call ourselves the NMC Alliance for short, and we are a nonprofit organization focused on eliminating minority cardiovascular health disparities. Our subgroup focus include African Americans, Hispanic, Latino, Asian populations, as well as American Indian. We are comprised of wonderful steering committee members, of who Dr. Kuntz is a co-chair, and they really span a wide breadth of fields, so including government, academia, medical associations, advocacy organizations, and more. So we're really happy to have a robust group that is open to dialogue around health disparities in minority populations. With that focus, we look at culture genetics, social determinants of cardiovascular health, and naturally we'll see that our work stream focuses on access to healthcare, diversity in clinical trials, and subgroup data. So there's certainly a lot of work that the Alliance does to move forward and make sure we're advocating on behalf of these minority populations, not only by taking a look at each individual group, but making sure that we take the strengths of each group and the learnings from each group to really pass on along learnings and strengthen the health outcomes. Today we're focusing on the Masterclass program, which is one of our signature initiatives. And with this, you'll see that there's still a vast majority or vast focus on these subgroups that I mentioned previously. And really, the purpose of the Masterclass program was really driven from the need and view that a lot of the providers in the group saw that there's additional education or additional learnings that can be received by patients and certainly optimize communication through patient and provider communication that we would like to help optimize in order to enhance treatment and provide greater health outcomes. So going into our methodology for the Masterclass program included in-depth interviews with providers, specifically providers that work closely with underserved populations that also treat dyslipidemia. We were also able to execute minority focus groups, specifically in the African American populations as well as the Hispanic populations, to get an understanding of how they view dyslipidemia, certainly in comparison to other conditions such as hypertension or diabetes, and then also understand if there are any barriers to communication that they are able to identify. Using this information, we were able to develop a toolkit as well as the training that we present to you all today in order to help optimize communication between patients and their providers. As you'll hear throughout the presentation, you're also able to incorporate the use of the coach model, which was founded by the Camden Coalition of Healthcare Providers. And so we're happy to talk about that and discuss how that can be implemented, certainly using the findings as a framework to optimizing communication between patients and providers. So next, I'll turn it over to Dr. Kuntz to talk about why we're focusing on dyslipidemia.
Thank you, Christine, and good afternoon, everybody. It's really a pleasure to be with you. I'm a primary care physician, as you heard, and of course, we're also focused on COVID, but I certainly know, and I'll bet all of you do as well, that our patients who have chronic conditions, whether it's cancer or cardiovascular disease or diabetes, will have lost ground. And hopefully, very quickly, we see the light at the end of the tunnel with the hopefully emergency approval of the vaccine today. And in a few months, I'm knocking on my desk here, things will start to return to normal. And then we're going to be needing to catch up quickly with our patients with these chronic conditions. And so today, as you've heard, we're focusing on dyslipidemia. An important term, it's not just hyperlipidemia, because we know that some patients will have disruptions of different lipid components, and it may not just be an elevated LDL. So why dyslipidemia, and why in a group of underrepresented patients? Well, as this slide shows, we sometimes don't think about dyslipidemia when we think about populations such as African Americans, Hispanic, Latino, or Asians. But you see in the bars to the right that there is a really high percentage of adults in these populations with an LDL level at or above 130, very similar to that of the majority population. And we really tend not to think about, I think, in many times, the importance of this risk factor in these populations. Next slide. So we're going to talk about some qualitative research that has been undertaken by our group, where we've talked to focus groups of African Americans and Hispanics to better understand their concerns about lipids in terms of their risk. And when we call this a master class, that might imply, oh, they're going to talk about a lot of drugs. Well, we'll talk about drugs a little bit in guidelines, but really what makes a master clinician is this ability to communicate effectively with all of their patients. So that's really what we're going to reinforce in this program. Next slide. So this is a bit of a busy slide, but I think a very useful one, and it speaks to the focus groups. There were 4 focus groups that were held, including which included about 30 individuals, 70% of whom were African American, 30% were Hispanic Latino. It involved a series of questions and conversations, and these were the results that I won't read every bullet on these slides, but you see some unique characteristics of patients in these populations. Socioeconomic status and patient education and health literacy are very important issues. Culture and background are important. Patients' understanding or perceptions of the value of over-the-counter or herbal medications is very important. So I think as clinicians, we need to remind ourselves, especially with these populations, that there are beliefs that are held that we need to, in a non-judgmental fashion, understand, appreciate, and at times, work collaboratively with our patients. The paternal approach of just giving a prescription and assuming that the patient will fill that prescription and take medication religiously has been shown to be unfounded. So we really need to better understand our patients and engage in a conversation, a two-way conversation, to help them achieve their goals. Next slide. So with regard to medication, the findings were interesting. Patients said that clinicians gave them a year to get their medications back in line before prescribing medications. This is that clinical inertia that we've often heard. In some instances, it may be entirely appropriate to continue to focus on lifestyle modification before we embark on medication. But if I were to give you a scenario where someone just came out of the hospital with a heart attack and we're back in our practice, they're well away from their target, I hope you would agree with me that we would want to start medication in that situation more quickly and more aggressively try to get to target to provide some protection. So we need to understand watchful waiting in the context of the patient's risk. Patients show confusion about which medications are for which their conditions. And this is where we're going to talk about the involvement of the entire office. It may not be the best use of that physician's time, and he or she may not be the best communicator. So it's really an office-wide approach to ensure that our patients leave our practices, leave our settings with a good understanding. Patients do not feel symptoms of high cholesterol, so natural aversion to taking medication, so that reinforcement of this is a lifelong condition, and it is taking that medication that is keeping your cholesterol levels under control. Patients don't read the information with prescription. This is a challenge, I think. I think we do want to be transparent, make sure patients clearly understand that there can be side effects and share with them what they may be, so they don't feel that they left and no one explained the potential side effect for them. So we need to focus a little bit on side effects, just so patients, when they get home and talk with their family, and a family member says, did the provider tell you about a potential side effect, and they can say with confidence, yes, he or she went over that with me. And we know that patients do not want to take a medication for life, and perhaps if a patient can lose weight, if that's the issue, can significantly change their diet, we're always going to be monitoring, and that's what I tell patients, and so it can be an ongoing conversation. Next slide. Perspectives from men and women are interesting and a little bit different. I'll leave you to just read all of the bullets. I think certainly in many cultures, it is the women who are very focused on health and somewhat traditionally perhaps on food preparation, but understanding some of the differences in women and men are important, so we can have the most effective conversations. Next slide. Clinicians believe that high cholesterol is less of a health concern for minority patients. I find that when I speak with my colleagues, when I'm on rounds, and we see an understandable focus on blood pressure, which is a huge issue in the African American community. Maybe 40% of African Americans are hypertensive. But as you saw on one of the earlier slides, hyperlipidemia or dyslipidemia is also a problem. And if our goal is to reduce total risk, we focus on smoking, we focus on, can people safely exercise? Can they make those dietary changes? Lipids, elevated or abnormal lipids is part of that equation. So we need to sometimes educate and remind our clinician colleagues that this is not just an issue in the non-Hispanic white population, but minority patients have lipid disorders that need to be addressed as well. Next slide. Clinicians in some of our focus groups said the following. They see a similar hurdle with regard to patients agreeing to lifelong therapy. Issues around insurance, whether it's a lipid a treatment issue or not, is obviously important. Something I speak with our medical students about several times a year is health literacy and the importance of us communicating in the appropriate language and level to ensure that our patients have good understanding. There is a belief that many patients will take natural remedies, and they will, but we need to have, again, a non-judgmental conversation so that we, one, understand what people are taking, and two, try to direct them to medications that have an evidence behind them. And that, I find, is not something that often takes place in a single office visit. It's creating that relationship with the patient, it's creating a confidence level to get there. And then patients will often talk about anecdotes involving family members, or, as I say, kind of the over-the-fence conversation with a neighbor that can often derail treatment recommendations. So we need to bring out those conversations as well. Next slide. So let me, Christine, turn it back over to you to talk about the coach model.
Thank you. So I'll give a brief overview of the coach model, and we'll hear from Dr. Koontz shortly about how to implement these methods. So as I mentioned briefly, the coach model was developed by the Camden Coalition of Healthcare Providers after identifying a need for more effective communication between patients. And as we've heard from Dr. Koontz, this model focuses and really emphasizes on trust, the respect, and non-judgmental partnership between patients and physicians. As you're thinking about the coach model, the best way to think about it is really a framework more so than it is, a checklist that can guide communication. So as you may have noticed by some of those, adjectives that I mentioned, being non-judgmental or having respect and trust, this is supported by 3 behavioral theories, that being the empowerment theory, unconditional positive regard, and trans-theoretical theory. And if you want to learn more about the individual theories, or certainly when we are able to distribute that toolkit, it really gives a deep dive into how each of these theories really inform the coach model. But taking a closer look at specifically the coach model, you'll see here what it stands for. C means to connect tasks with visions and priorities. O, observe the normal routine. A, assume a coaching style, so looking at I do, you do, we do. C, create a backwards plan. And then H, highlight the progress and process with the data. Again, Dr. Kuntz will go into this in greater detail, really talking about implementation and how we can take the learnings not only from the findings that he reviewed, but also how we can use it, how physicians can use it, the coach model, in order to effectively communicate with patients. So I will turn it back over to Dr. Kuntz, who will review the guidelines and therapies for lipid lowering. And as part of that, Dr. Kuntz will go over the coach model.
Thank you, Christine. You know, I remember the days where if a patient didn't follow the physician's guidance or recommendation, physicians would say, well, it's the patient's problem. I think what we're learning is we have a real responsibility as the clinician to work collaboratively with our patients to achieve the best outcomes. That's a really important fundamental difference from where we were 10, 15, 20 years ago with where we are today. And the coach model, I think we always can learn, even around how to be good interviewers and how to connect with our patients. Okay, in terms of guidelines, we sometimes get lost in the fact that there is still a regular and deep review of the management of patients with hyperlipidemia. I would say they haven't changed dramatically, except for the introduction of some newer agents for a subset of our patients. But in 2018 and 2019, from the American College of Cardiology and the American Heart Association, we did have some new guidelines. So we'll go through these rather quickly. Next slide. So the American Heart Association guideline really focused on primary prevention. And again, by definition, these are patients who do not have never had an event. And so our focus is really about lifestyle. It's about a regular assessment of that patient's lifestyle. It is encouragement to address exercise, diet, other risk factors such as cessation of cigarette smoking. If patients fail lifestyle and would need to go on treatment, statins remain first line for patients, either a moderate or high dose statin. And we've used the number of 70 as the kind of the target. Some may remember back in the day it was 100. But if patients do have atherosclerotic cardiovascular disease, really the target to achieve is 70. If we can't achieve that with statin alone, we would add ezetimibe, and we'll talk in a minute about some of the newer agents if patients are still at that, not at that target of 70. Next slide. This is a busy slide. I won't go through it. I just want to pick out one word that you see pretty much throughout this slide, and that's discussion. And this kind of relates us back to the coach model. It's a conversation with patients. It's not just about printing out the lab result, looking at a number, handing a prescription, and going into the next room. It's really about trying to explain, which can be a difficult concept, the concept of risk to a patient, the idea that they need to address other issues such as their smoking, their exercise level, but at the appropriate combination of level of LDL and presence of risk factors, they may need to start pharmacotherapy. But it's always about a discussion. Next slide. So to make these take-home points a little bit more concrete and easier to follow, these three circles I think are a good way to do it. Lifestyle modifications are always part of the conversation, even for patients who have needed to go on therapy, but it's always part of the conversation. Then conducting a risk assessment. Many of these you can download an app on your phone, plug in the numbers, show it to the patient, or they can do it themselves, and they can really understand the concept of risk. And then in selected circumstances, prescribe pharmacotherapy. One of the things I would point out on this slide that was something discussed some years ago was the role of aspirin, and that is no longer routinely recommended in the highest risk patients. So that's somewhat of a change from some earlier guidelines. As you can see on the bottom box, clinicians should evaluate social determinants of health that affect individuals to inform treatment decisions. So things like finances. I think most statins, if not every statin, is generic, but finance is a social determinant for everybody. And if that is an issue, we need to take that into consideration with what agent is available. We often see this challenge when people are discharged from the hospital. If a clinician is not attentive to the issue that this patient may not have insurance or may not have the right insurance, that fancy drug that was prescribed in the hospital, they show up at the pharmacy and they just can't get it. Next slide. Good. And so kind of going back to the role of the National Minority Cardiovascular Alliance, we do want to keep reminding clinicians and patients that lipid disorders are important in underrepresented populations, and they can influence estimates of risk. In South Asians, there's a heightened risk of atherosclerotic cardiovascular disease. In patients of that ethnicity, there may be an increased sensitivity to statins in East Asians. There can at times be an overwhelming conversation around hypertension in African Americans, and not enough time or effort may be given to another modifiable risk factor like hyperlipidemia. And higher rates of risk factors for atherosclerotic cardiovascular disease are seen in Native Americans and Alaskan Natives than in non-Hispanic whites. So these ethnic and racial backgrounds can have an impact on atherosclerotic risk. And unfortunately, we don't have as much data in the decades of research in these populations as we do in non-Hispanic whites. Next slide. Secondary prevention is something I think everyone is familiar, has seen something like this. These are our patients who have had symptoms. They may have angina, they may have had a TIA, they may have peripheral arterial disease. So they're at a high or very high risk. They may have had a recent myocardial infarction. And so we are much more likely to quickly move to statin therapy, either moderate or high dose, and in a smaller subset of patients who are at very high risk and can achieve their target, as we said, on a statin and ezetimibe, or perhaps can't take a statin, we have some newer agents that we'll touch on in just a minute. Next slide. So again, kind of a simpler take-home type of slide here. Lifestyle modifications, which we've talked about. Initiation of therapy based on risk. So it's a combination of levels of LDL plus the presence or absence of risk factors. And again, this is something that can be fairly easily calculated and with the patient's involvement. And then assessing progress. So it's not treatment and then completely walking away. It's monitoring, it's an ongoing dialogue so that patients stay adherent. Next slide. There are a number of myths about lipid-lowering agents. I think in my career, I've heard all of these. That statins hurt one's ability to exercise. Statins cause muscle damage and can hurt a patient's heart. Statins should be avoided in the setting of diabetes. Statins can cause cognitive dysfunction or frank dementia. Natural supplements like red yeast rice are safer than statins. Statin intolerance means that a patient can never take a statin in the future. Statins cause cataracts and liver damage. And on the other hand, everyone should take a statin, and the elderly do not benefit from statins. And I think we could spend time talking about each of these statements. They are all wrong. I think we need to, as clinicians, talking to our patients, need to see if they hold any of these beliefs and discuss them with them. Because if we don't, again, kind of what the coach model wants to make sure we emphasize is many patients will have these beliefs. They may not be willing to share them with us. They may accept the prescription, nod their head, walk out the door, and never fill it. So we need to say, do they have some disbeliefs, some misunderstandings that we can correct that will reduce one more barrier and increase adherence? Next slide. The point of this slide, which has the acronyms of a lot of lipid research studies from over the years, is it's consistently been shown that the lower the level of LDL cholesterol, and that's seen on the x-axis, the lower the event rate in secondary prevention studies. So when you take this overall, patients who have a lower LDL are less likely to have a subsequent stroke or heart attack or symptomatic peripheral arterial disease. And that's been seen with different statins, and as we'll see in a minute with some other agents as well, in different design studies. So there's a strong linear correlation. The statin hypothesis has really been proven without question. Next slide. So we have some new agents. We're not going to spend a lot of time talking about these, but it's exciting to remember that in the last maybe 4 or 5 years, we've had the introduction of drugs that are called Pcsk9 inhibitors. They, as I said, they can lower LDL very effectively on top of statins or in the setting where a patient simply can't take a statin. These are 2 slides from 2 of the bigger studies, about 20,000 patients in each study, patients with either an acute event or chronic atherosclerotic disease. And when it says placebo, that is in the setting of standard of care treatment, and then a group of patients randomly received either the every other week or monthly injection of the Pcsk9. And in both examples, the results were very powerful. So it doesn't just lower lipids by about 60%. So these patients ended up with LDL levels in the 30 to 40 to 50 range. But that did translate into fewer events, fewer heart attacks, fewer subsequent strokes. So really exciting that we have this new addition to our armamentarium for patients who cannot get to target and are very high risk. Next slide. We also have another new entry called Bimping Acid. It's available. We don't yet have outcomes data yet, but you can see that it also lowers LDL and non-HDL cholesterol compared to placebo. So a patient who had a level around 102 was lowered to the mid to high 80s, and that was persisted for about a year, and a similar trend with non-HDL cholesterol. So again, there's still activity in this field, new agents coming to market that can help us in those instances when a patient may not be able to take a statin. We have some new options for them. Next slide. As I was just saying, bempedoic acid has been shown to have benefits across the board in patients who cannot tolerate any dose of a statin. And so this is not just a lowering of the LDL cholesterol and of the total cholesterol, but of other components or other things that may influence risk, such as high sensitivity CRP or apolipoprotein B. So benefits across the board in patients who can't tolerate a statin. Next slide. And in addition, when this drug is combined with ezetimibe, we see a benefit beyond each individual component. So I think this can clearly be shown in looking at both LDL in the bars in the table to the left and high sensitivity CRP change from baseline to the right. There may be a component of inflammation in the setting of hyperlipidemia that influences events to happen. So reducing a marker of inflammation like high sensitivity CRP is becoming increasingly important in addition to lowering LDL. Next slide. What about fish oils? Well, some new data around icosapent ethyl, a fish oil for the treatment of patients with hypertriglyceridemia. This has always been somewhat of a point of curiosity or lack of clarity. What role does a triglyceride play in terms of cardiovascular risk? Well, this study shows that not only with 4 grams a day of fish oil do you see a reduction in the level of triglyceride, you actually see an improvement in fewer events. So Another option for that group of patients who has an elevated triglyceride, what about the evidence around fish oil with this formulation? We seem to see very positive results. Next slide. This is kind of interesting to think about this on a day when we may see the coronavirus vaccine approved. I think we all appreciate that around the country there is a lot of anxiety in minority populations for many things in research and in treatment. And this is somewhat translated perhaps into findings in dyslipidemia drug trials. And this is something as a clinician, when I meet with someone who's telling me about a new drug on the market, I really question them about how, what was the effort to enroll minorities into that research trial. So with the two Pcsk9s, the percent African Americans was less than 3%. With the Bimping acid in one of those two studies, the enrollment was less than 3%. We do see some examples of a commitment to enrolling a large number of patients. And this is a multifactorial problem. It may be a lack of minority investigators. It may be investigators that don't have access to minority populations. It may be anxiety that minority patients have when presented with the opportunity to be part of a research study. So there are a lot of issues here, but the bottom line is we need collectively in I think the healthcare community to do better and have an ongoing commitment to ensure that we have information about a drug class or an individual drug in patients in whom we plan to prescribe it. Next slide. This has also been shown in some of the older statin trials where either the percent of underrepresented populations did not come close to matching that of the population at large, or there really is no information about how many minority patients were involved in these studies. Now we have seen successful treatment of all populations with regard to statins, but nonetheless, we, I think, need to keep pushing, whether it's the federal government or an individual company, to ensure that there is adequate representation from all groups that will receive the drug at the end of the day. Next slide. So finally, another example of a drug that will affect the Pcsk9 mechanism. This is a RNA drug, so it has a different approach to impacting Pcsk9 inclisiran, and this was also published in the New England Journal a couple years ago. This may have the benefit of a less frequent dosing schedule as well as lower cost. So something else to look forward to. And I think it is exciting that there is still a lot of drug discovery, and for our highest risk patients, we will have a number of new options either now or in the near future. Next slide. So let me keep going. The coach model, which Christine mentioned to us, is really important. I think this slide, that it's a shared responsibility in an office to reinforce messages, and everyone can play a role. If we speak with one voice, if we are listening, if we do motivational interviewing, while we're following guidelines and have cultural sensitivity, we will, I think, really meet and exceed our patients' expectations. Next slide. So you saw Christine with this. This is kind of a nice to remember what this is all about. Connect with the patient's vision and their priorities. Observe the patient's normal routine. Assume that coaching style, that you're in this with the patient. We are going to get down to the target. We are going to work together to address your diet. We are going to come up with an exercise plan that is practical for you to achieve. Create a backwards plan. I'll show you what that looks like in just a second. And highlight progress and process with data. And with the patient's consent, I'd love, time permitting, to call a family member if they're not in the room and say, great news about mom's cholesterol, today's visit. We just need to make sure she keeps going with her diet, with her medication, whatever it may be. And that patient or that family really loves to hear about that type of progress. Next slide. So I won't go through this in detail because we've kind of talked about the C is for connect. Next slide. O, observe the normal routine, and I do like to focus on health literacy, something that I speak to our medical students about. As I said, I think it's really important to make sure that we're speaking at that patient's level. We use a teach-back method, so I often will, as the Institute for Healthcare Improvement has put this into their model, clinicians should say, many patients, I talk to many patients every day about cholesterol levels, and I want to make sure that I'm clear. So can you tell me, what you're going to take away when you get home tonight and talk with your daughter? So was I clear? Not did they understand, but was I clear in how I communicated that message? Next slide. Assume a coaching style. We talked about this, that you are that patient's coach. You're working in tandem with him or with her, and they feel that you are with them, that you're not talking down to them, you're not creating unrealistic expectations. And so that coaching approach is really important. Next slide. And this is that backwards plan. So thinking about how to achieve that goal. So let's say a patient is not in the very high risk group. They didn't just have an MI, they don't have multiple risk factors. So we have a little bit of time, but maybe they have failed a diet, or they failed diet and exercise. We determine what their goals should be. We'll use our risk calculator, and then we develop a backwards plan toward today. Say, okay, 6 months from now, we want to get our LDL down to 100. How are we going to do that? And then helping them work backwards to say, okay, this is where we're going to start, and this is where we're going to end, and let's talk together about what those steps are, whether it's with your diet, with your exercise, with medication, to get there. Next. And finally, the last of the letters of coach, highlight progress and process. And as I said, connect with patients, have the patient bring in a diary where you're sure you're writing the numbers down. Many of us now have portals where patients can go in and look at their results, encourage them to do that, encourage them to share that with family who can support their progress. Next slide. So again, coach, C-O-A-C-H. And next slide. So I think we've achieved the end of our program. We've got time for questions. This is a nice reference, and we're happy to maybe come off shared screen, and we can either take questions that may be in the chat, or you can unmute and we can have a conversation.
Thank you, Dr. Kuntz. I do have a question from the audience. I got a couple coming in here. So the first one is from Andrea, and she asks, what is the current feeling on what is a healthy diet? She has seen models from Dean Ornish to a very generic plant-based. And then is there a difference for those with a low to moderate risk versus those that have already been diagnosed with dyslipidemia?
Yeah. Well, thank you for the question, Andrea. And I'll preface by saying I'm not a nutritionist or a dietitian. So my comments are going to be more high level as opposed to detailed. And I would defer to a dietitian. Maybe there's one on the call. I think that the diet has to match the realities for that patient. So I think there's general agreement about less saturated fat, for example, whether it should be plant-based versus lean meat, I think would be influenced by what that patient is likely going to be able to follow. And I think that's an important, from my standpoint, an important concept with a lot of things. We might have a diet that's in a national guideline, but it's going to have to be modified to meet the needs of that patient. So whether it's that Mediterranean diet, I think they generally have common themes of more fresh fruits and vegetables, lower, milk-based products with less fat, less saturated fat. So I think there's some common themes. I think that gives us some flexibility to a particular diet that meets the needs of a particular patient.
Thank you. Andrea would like to follow up. So go ahead and unmute yourself, Andrea, and follow up with that question.
Wonderful. Thank you, David, and thank you, Dr. Kuntz and your team for taking my question. So I am a dietitian.
Perfect.
And so the reason I asked was that very reason, that I don't think I've ever seen anything that was incredibly solid for dyslipidemia or even cardiovascular disease in general. And I was just wondering if your team, especially due to your experience with working with minority populations, underserved populations, that if you had seen anything where there was real clear success between one versus another, because they do vary, the dietary patterns vary so widely that you get things that are just so strict, like the Dean Order's diet that's a low-fat vegan, completely plant-based type of model, all the way up to you should really eat some more veggies. That would be a good way to go. And just as clear as mud is that. So I was just curious if you had seen anything in specific, and it doesn't sound like you do, which it's kind of a good thing, because I think you're right. You get a chance to be more responsive to the individual's needs there.
I agree with all of your comments. I would say, as I'm sure you're aware, in hypertension, with another risk factor, we've seen probably very good results with the DASH diet. That's probably the one area where, if you want to match a cardiovascular risk, particularly in an African-American population, and a diet that can be modified, and actually there are ways to, you can find a DASH diet that, is a soul food DASH diet, if you will. So you can find the DASH diet, which is studied for so many decades and has been modified that may particularly meet the needs of individuals of different race or ethnicity. But I haven't seen that in dyslipidemia. But I think even a DASH diet would start to achieve those benefits, not just in terms of blood pressure control, but perhaps with dyslipidemia as well.
Great, thank you so much.
Excellent, thank you. I have a couple more questions for you, Dr. Kuntz. If anybody else out there wants to ask them themselves, please send me a message in the chat, and we'll get you unmuted and you can ask yourself, or continue to write them in the chat, and we'll make sure that we get through them all, or I'll send them home with them as some homework, and they can send me back the answers that I'll make sure I get to you. So Carrie asks, she says, enrolling minorities in clinical trials historically has been challenging based on trust concerns, which is understandable. And other than the standard of care for obtaining consent, do you have any recommendations for further discussion with minority patients on enrollment that would come across as coercion during the consent process? Would not come across as coercion. Sorry.
Yeah, no, it's a really, I'm so glad the question came up, and I'm going to give a short answer so we can get other questions. I think it's a really sensitive issue. We have been involved in my health network with the Moderna COVID vaccine. And we made a specific outreach to churches, to community groups, to community leaders, in settings where we understood that there was anxiety. We understood a legacy of distrust. So it's really about listening. It's about giving people time to talk with their pastor or talk with their family. We had a number of African-American physicians, such as myself, kind of talk about what we have done, both within our network and recently nationally, to ensure safety and better accountability in research. And having said all of that, I'm not unrealistic to think that just by doing a couple of sessions like that, people are going to necessarily change a legacy that they live with for many years. So it's about getting the message out. It's about reaching community leaders. It's about listening and having sensitivity. It's about answering questions. I think it's all of those things, and I think we have to still have a degree of patience. Now, having said all of that, it doesn't mean that we don't hold, let's say, the pharmaceutical industry accountable to do the outreach. It's not enough to say, well, gee, with all of those barriers, I'm not even going to bother trying to enroll African American or Hispanic patients. That's, to me, the wrong answer. We have to have all of those other pieces in place. We have to do the community outreach. We have to enroll more clinicians, whether they're minorities themselves or not, who have large African American populations. So it's going to be a lot of things. And I think even with all of that, it's still going to be a slow rise in enrollment because we have an unfortunate legacy to overcome.
Excellent. Thank you very much. We have a question from Kim. Kim asks, are there any strategies for more effectively delivering these health messages via telehealth? Do you have similar trust issues related to the online platform?
Actually, that's a great question, Kim. I'm not sure we have enough data yet, whether it's for minority populations or other populations. I think one thing that will stay with us after COVID is much more acceptance of telehealth from providers and patients. And so I think you raise a really interesting question. It's much, I think, in some extent, I can sit with a patient, I can describe a research study to them, I can describe a medication to them, my nurse can go in after me or my medical assistant. But on a telehealth visit, it's either a phone call or a video visit, and it's kind of me, the patient, and then I'm off, I'm jumping onto another call. So I think it's a really good question. I think we're going to have to better understand adherence after a telehealth visit, enrollment and research after a telehealth visit. How can we incorporate this coach model when it's often just the clinician and the patient? So I think we're entering a bit of a new world that we're going to have to, perhaps adapt some of our traditional approaches.
Excellent. Thank you. I think that is the end of the questions that I have in chat. Several people want to thank you for doing this today and for providing the feedback and the conversation. They have loved it. Just going through here. I don't think I've missed anything. I do not see anything. So we have no more questions here. Benita, do you have any more questions? You are muted. There you go.
Not a question, just a statement, and I wrote it down because I'm actually originally from Eastern Kentucky, so I have heard of a lot of natural remedies, but when you noted that, I don't think I have ever heard of a natural remedy for cholesterol issues. That was an eye-opener for me. What would that entail? I mean, what's the thought process?
Well, I think that first of all, people many times gravitate to something that is advertised as herbal, natural, organic, and yeast products have in some parts of the country at least been touted as a natural, safe remedy to address cholesterol. So people have a reticence to take prescription medications. We know that. People often gravitate towards something that's described as herbal, organic. But we also know that many of these products are not regulated. The regulation is different than pharmaceuticals. I'm not always going to defend pharmaceuticals, but for something as important as someone's cholesterol level, again, it's not about, as a clinician, saying, that's a stupid idea. That's the easiest way to turn off a patient, to lose their trust and lose their connection. It's about listening, understanding their point of view, providing your point of view, encouraging them to maybe look up things yourself, or you can provide something at the appropriate literacy level to say, hey, I think this is a better approach for us. Here's the safety, let's go over myths that you may have heard about with statins. So And I think this is just one example that we, you know, people come in my office every day with various belief structures around natural remedies. And so I think we need to have a sensitivity to that, whether it's around cholesterol or other things, and have this type of conversation going forward.
Thank you. And thank you all. We really appreciate the conversation. Excellent presentation, good conversation afterwards. So we appreciate your time today. I think it was a wonderful inaugural of our TAS Talks.
Well, thank you. And I think on behalf of the Alliance, we were excited to be with you, and we wish you all the best with your series of future webinars. And we're honored to have been your first for this new series.
Thank you all. David, anything else?
No, thank you so much. Christine, I will send you some emails. We'll continue this. I will, yeah, we can handle all of that offline. Thank you so much, everyone. You guys have been great to work with. I appreciate so much. And I look forward to possibly doing this again sometime or with some other venture.
I think it would be our pleasure.
Thank you all.
Bye-bye.